Good afternoon. Welcome everyone to our session on albumin. And it's an honor to be with all of you today, finally in person again. It's been too long. My name is Paul Wischmeyer, and I'm a professor of anesthesiology and surgery and a critical care attending at Duke University in Durham, North Carolina from the US. It's nice to be out of the US finally for a little bit. And I'll introduce my co-moderator.
Yes, my name is Arthur van Zanten. I'm intensivist in Gelderse Vallei Hospital in Ede, the Netherlands, and a professor at Wageningen University and Research. And it's a pleasure to chair this session with Paul. And now let's see, we have to introduce the first speaker. You have it ready there?
I do.
It's Dr. Robert Hahn from the Södertälje Hospital in Sweden. So the floor is yours, Dr. Hahn.
Thank you. I take this off now so we feel a little better. Yes, I'm going to talk about the kinetics of albumin and compare it with crystalloids. And we'll be mainly focusing on the plasma volume expansion. Now I hope to change slide. Do I hold it in some direction? Yeah. So we will discuss the plasma volume expansion of crystalloid fluids and compare it with the albumin and say a few words about the albumin mass kinetics as well. So let's start with the crystalloid fluid. Historically, the plasma volume expansion of crystalloid fluid has been studied with radioactive tracer techniques. And what we then find is that the volume expansion is very low, below 20%. The downside with this technique is though that it doesn't capture dynamic events that well. It needs to a period of steady state, which has been a problem. An alternative method is volume kinetics, which is a pharmacokinetic approach. And that is built on that we have repeated measurements of the hemodilution, about 25 to 40 measurements in series. And we have a measurement of the urine excretion, which is this arrow down there. If we do that, we'll see that we can calculate all the volumes and all the flows involved in the model. And what becomes apparent then is that the distribution here between the plasma and the interstitium is not immediate at all, which is in, for example, cats and rabbits, but in humans it's not. So it takes around 30 minutes for this distribution to be complete. There is an average half time of 8 minutes, so four times 8 minutes is the complete distribution function. So it looks like this. If we infuse 2 liters in a volunteer, that we have a volume expansion is quite good to begin with, but as soon as we turn off the infusion, it falls down to the level that we saw from the radioactive tracers study, about 15 to 25% of the infused volume. This top here will be very much dependent on the rate of infusion, and the slope here will be very much dependent on the urine flow. This is an example of the importance of the distribution function. If we infuse fluid quickly, we'll get a very prominent phase. If we give it slowly, the impact will be very much slower. Now you may wonder, is there any situation where this will change, or is it always like this? Now there is one setting when we have a major change in the kinetics of crystalloid fluid, and that is when we have a sudden decrease in mean arterial pressure. Then the distribution goes down, and it can actually temporarily be 0, which means that all we infuse accumulates in a plasma. And also the second important thing is what I wrote down at the bottom here, that the rate of elimination is very much inhibited. So elimination will be very slow during general anesthesia. And the reason for that is partially age, but mostly the reduction of the mean arterial pressure that we see during general anesthesia. This is a computer simulation based on 75 patients and volunteers, where we see the proposed urine excretion after infusing 1 liter of ringers here. This is the expected outcome. And when we have a situation like that with reduced arterial pressure, that means also that the plasma volume expansion will increase and the interstitial fluid accumulation will be greater, just because the elimination has been slowed down so much. So these are the basic things that we need to remember about the crystalloid fluid kinetics. We have a prominent distribution phase, elimination, distribution half-life of 8 minutes, and then we have an elimination function that is very much dependent on the mean arterial pressure. So if you compare that to albumin, we'll see the major differences here. We don't have any distribution phase at all. The half-life, or the intravascular persistence time, which is a kind of better expression perhaps, is very long, 6 to 10 hours, half time, which means that the effect remains the next day, actually. And if we have 10 hours half time, it means that the effect doesn't subside until 2 days later. So this remains in the circulation for a very long time. It's dehydrating, which means that the urine excretion will be larger than the volume we have infused. And this is an interesting point too, that the elimination is not changed by surgery. Now I'll show you a couple of examples of the fact that the plasma volume expansion is very stable between experiments or between clinical situations. This is first a comparison now between volunteers and postoperative patients, where they have undergone really major surgery in the morning after this. And we see in both cases that we have a plasma volume expansion about twice the infused volume, and it subsides very slowly. And there's no statistical difference actually between the two situations. Here is post-burn, 1 week after burn injury, and we have an inflammatory situation. That's the problem at this time. Again, the plasma volume expansion about twice the infused volume, no difference between post-burn with inflammation and healthy volunteers. And we see the estimated mass balance calculated capillary leakage is about the same. Third situation now here is we have general anesthesia. We have reduced the mean arterial pressure in the patients by 40%. So this is a hypotensive situation which would have changed the kinetics of a crystalloid solution very, very much. But here we see no change. It's the same, the urine excretion is the same as we have had in the volunteers. And we have a plasma volume expansion that's 1.7 times the infused volume. So in this setting, the albumin is the only fluid that was used during the operation. Next slide is from the current issue of Anesthesia and Analgesia. Here, the volume expansion from the albumin solution has been calculated differently. This is a regression method, but we see that the expansion is about the same, 1.9 times the infused volume, although we have a hemorrhage situation here. And alongside crystalloid is infused, and you see we have a much greater volume expansion here than we have in the experimental setting that I began with. And of course, that's because we do have a low arterial pressure, that reduces elimination, and also that we have a continuous infusion, which means that some of the distribution effect will be seen here. All right, what about the 5% albumin solution? We've done one volunteer study of that. The plasma dilution, which is an inverse really of the plasma volume expansion, is almost the same. So that means that a lot of the volume in the 5% solution leaks out more or less immediately. And you see here, this is the volume expansion compared to the amount that we have infused. There's a much lower, of course, with a 5% solution. Urine excretion is almost the same. There's a little more with a 5% solution because we give much more here. This experiment is matched so that we give the same amount of albumin in both situations. So what about the albumin molecules? The capillary leakage, of course, is a continuous thing. It's a half-life of about 6 to 10 hours. Actually, it's longer during general anesthesia as far as we have found. It's a little faster for fluid. So with this elimination for fluid and this for a little more straight for albumin, if we combine them, it will mean that the plasma volume, the plasma albumin concentration will be quite stable for many hours after you have infused this.
C'est qui est dans la copper
So
là?
let me make some conclusions then, that for the crystalloid fluid,
Okay.
we do have a short-term plasma volume expanding effect around 50%. But as soon as we turn off the infusion, it goes down to what we've seen in the medical textbooks. 20% albumin expands the plasma volume 170 to 200%, and 5% albumin by 70% of the infused volume. So the difference is between them is not a factor of 4; it's less than 4. Also, we must acknowledge the very long half-life of the albumin infusions. So the effect extends to the next day and sometimes to 2 days. Also, there's a marked difference here that if we use hypertension,
Oui, dis, moi j'ai pas d'image de la copper là. T'es pas loin, est-ce que tu sais voir si c'est normal? Parce que moi j'ai du son mais j'ai pas d'image. Et je vois que leur caméra, la caméra du copper live.
volunteers with the albumin solution. Okay, and I also think I've shown in a number of studies that plasma volume expansion is quite stable. By that, I thank you so much for your attention.
Thank you very much for this excellent presentation. Are there any questions in the room?
Yes, so
Yes, please.
I have. Do you hear me? Yes. I have 2 questions. So the first one is that sometimes we try to use albumin for volume expansion for make a fluid challenge, but you show how 20% albumin it expands the plasma volume 2 times. Yes, it's more that you give that it's expanded. Yes, but how much time do you need to it happens? How much time you need to have this twice the volume of expansion? In 5 minutes, in 30 minutes?
You mean how fast the plasma volume expansion comes?
Yes.
Yeah.
It comes with a delay of 10 to 15 minutes. So it's not immediate. So the maximum volume expansion when you infuse 20% albumin does not come at the end of the infusion. It comes about 15 minutes later.
Okay, thank you. And the second question is just, you show how if you give 20% albumin, you are dehydrating the patients, or you induce diuresis because you have probably more volume. But do you think could be beneficial in the patients that have already resuscitated and that they have fluid overload by redistribution of the fluid between the compartments?
I think I understand your question. Your question about edema?
Yeah. Distribution from other.
Yeah, it's a bit different here, the thoughts. No, I believe, and I'm about to demonstrate now, we're working on it, that this really comes from the interstitial fluid compartment. There's some thoughts here that the recruited fluid, that the excessive expansion comes from the glycocalyx. That's another possibility, actually. It would be quite logical, but we will find out soon if this is the case.
Maybe a short last question. You showed for experimental reasons that you infuse like in 30 minutes and then you see the slopes of the effect over time.
Yes.
What happens when you would give it like a more continuous infusion?
Yeah. If we give a continuous infusion, the importance of the distribution function will be less.
Yeah.
And it's the same with all drugs actually that have an exponential distribution. Actually, the best volume effect, the most pronounced plasma volume expanding effect of crystalloid by a specific amount is to give it slowly.
Okay.
Just one touch question I've always wanted to ask from someone who does research like you. We get criticized often in patients with sepsis or high CRPs or an inflammatory response that when we give albumin, it leaks out anyway.
Yeah.
Do you think that happens? Does it leak out even in a patient who's got a septic or an inflammatory response occurring?
I didn't understand the question.
So does albumin leak out of the vasculature in the septic patient?
Yeah.
Does the vasculature become permeable enough to allow it to leak?
The albumin leak.
In say, in sepsis or an severe inflammatory response?
You ask about the capillary leakage of albumin, right?
Yeah.
Right. Actually, this is an interesting point of the studies that I've seen being produced in Bern and so on. That we don't see increased capillary leakage, but with the method we use, and that's very important. That's mass balance calculation. That is the sum of capillary leakage and lymphatic return. Now, we cannot distinguish between the two. So that's a caveat here. But I think this mass balance calculation tells you really what is important, because if it leaks faster, it doesn't matter so much if it comes back from the lymph. But I'm a bit amazed. Like we had a couple of situations here with really inflammatory reaction from behalf of the patients, and I would expect the capillary leakage to be increased, but we didn't find that. So probably it needs quite a large impact to the body to see it.
Great. Thank you. That's excellent.
You take the next, or I can announce the next speaker. The next speaker is Jonathan Barnard Smith from the Manchester Royal Infirmary in Manchester, UK. And the title of his presentation is Beneficial Effect in Critical Illness. It's difficult with all the apps. And,
Yeah.
The floor is yours. Thank you.
Thanks very much, and thank you for the invitation to be here today. With a somewhat Herculean task to try and distill the vast, amount of literature that's out there on albumin and our quest to find who it helps. But I hope that I can just focus maybe down to about 2 or 3 areas to give you some food for thought about how we might use it to help patients with critical illness. So to begin with, I do have some declarations of interest to mention, and perhaps most importantly is the personal one. Because in an area of clinical practice that has a fair bit of influence in terms of clinical culture or physician preference, I'm going to admit to you that I do give albumin to patients in critical care, but I can't tell you with great certainty which ones gain true benefit, but I would like to find out at least, so yeah. So if we're going to begin clinically, the clinical use of albumin, we can't get through this talk without mentioning the SAFE study, of course, which enrolled thousands of patients and compared those receiving isotonic albumin preparation versus 0.9% saline for fluid resuscitation for all comers to the ICU. And I'm sure you're all aware there was no difference in the primary endpoint for this trial in terms of mortality between the 2 groups. But this trial was partially done in response to concerns about the safety of albumin in critical illness. And so one of the results that we could look at it is that albumin it was confirmed as being safe as a resuscitation fluid. And it also had similar resuscitation endpoints compared to saline, as you can see with this graph here of mean arterial pressure in the first few days after ICU admission. What the investigators did also show in the supplementary appendix is that the use of albumin was associated with lower volume requirements overall. And of course, there's the much heralded subgroup analysis of this trial, which showed that those with severe sepsis and septic shock appeared to have a lower mortality rate, which identified that subgroup for further investigation. We've also looked at albumin as a resuscitation fluid, but we've focused on the hyperoncotic preparations, the 20% albumin. And looking at a very similar population of patients to the SAFE study, we randomized them to either receive 20% albumin versus the 4 to 5% preparation for all fluid resuscitation after they've been admitted to the ICU. And we also found, like the investigators in SAFE did, that the resuscitation endpoints were exactly the same between the groups. But those who received 20% albumin required far lower volumes of fluid to do so, as illustrated by the total volume of resuscitation fluid on that previous graph there. Sorry. We also found that there were some other favorable outcomes, so including cumulative fluid balance at 48 hours, and also the peak levels of serum sodium and chloride, which of course have become much more of a concern, particularly with hypochloremic acidosis, compared to those patients receiving the 4 to 5% solutions. So that's albumin as a resuscitation fluid clinically, but I know that it's also used as a regular supplement. And the Albus trial, published a few years ago, of course, a multi-centered randomized controlled trial of patients with severe sepsis and septic shock. Note that this was prior to any change in definition with the publication of Sepsis 3. And again, there was no difference in the primary endpoint of mortality between the two groups, who were either allocated crystalloid therapy alone or a regular daily supplementation of albumin based on their serum albumin values. But again, the investigators report a favorable amount of cumulative fluid balance in the early days after enrollment. And again comes this tantalizing subgroup of patients with shock who appear to have their shock resolve quicker if they receive albumin, which may translate to a lower mortality rate. So that's the sort of clinical, headline figures in use of critical illness. And really, if you go any further than that, you really need to start understanding some of the basic science, some of which we've heard previously from Dr. Hahn. And it is important that we understand where we're giving the albumin to and where it might end up and why. So this is the glycocalyx in your endothelial lining your endothelial cell layer that I like to think as this rainforest on the forest floor of your endothelial cells, reaching up a whole mishmash of peptidoglycans, proteins, and other molecules, and serving a really key function in several homeostatic mechanisms, but intimately interacting with the plasma above it. And it's more like a gel rather than a sort of fixed, hard structure. It's more like a gel that's ever changing in nature, shape, and form. But of course, if we think about it as a rainforest, when we have insults like sepsis, inflammation, trauma, it becomes damaged. And the glycocalyx thickness is shed into the circulation, and we start to get exposure of endothelial cells underneath. And this leads to exposure of adhesion molecules, which is how you activate your neutrophils, and then they can cross your endothelial cell layer into the interstitium, which is all good if you're fighting infection, but we see it when in episodes of patients' over-exaggerated immune response in conditions such as septic shock. So much as the world has done to our rainforests, insults such as sepsis turn the glycocalyx, if you pardon the analogy, into this sort of picture that you see on the right-hand side. And the real question is can albumin, or isn't the evidence of albumin, actually being able to augment or protect against this process? Well, Matthias Jacobs' group have tested this into an ischemia reperfusion model in guinea pigs. And they took guinea pig hearts, gave them an ischemic insult, and then preserved them in a number of different solutions, ranging from a control solution that you can see on the left, a heparinase solution which is known to cause glycocalycal shedding, and then a standard electrolyte solution called the Brett-Schneider solution, or the Brett-Schneider solution along with albumin. And you can see that when they reperfused the hearts and then looked at the amount of leukocyte adhesion, so neutrophil activation is this scale on the y-axis, you can see that those hearts that were exposed to the electrolyte solution and albumin, when they were reperfused, had very similar leukocyte activation rates to the control group. Whereas those who just received the electrolytes alone have a similar amount of leukocyte activation as those that were intentionally given a glycocalyx shedding agent. Moving this forward into a resuscitation model, There's been a study that's reported in rats. If you exsanguinate a rat by about 40% of its blood volume and then resuscitate it, you can actually measure the glycocalyx thickness using some quite sophisticated microscopy. And you can relate that to the biomarkers that we have previously recognized as measures of glycocalyx injury. So here, using a variety of fluids, they've resuscitated rats with fresh whole blood, packed red cells, FFP, albumin, and then crystalloid solutions, including your Hartmann's, lactated ringers, hypertonic saline, and normal saline. And both these relationships are looking at glycocalyx thickness on the y-axis and correlating it to these biomarkers of glycocalyx injury. And you can see here that albumin stands at the top of the fluids that we would commonly use to resuscitate patients in critical care. Not quite good as whole blood, which is sitting up here, but certainly better some of the crystalloid solutions that we've seen. So it appears that the use of albumin in resuscitation, certainly in this rat model, appears to maintain glycocalyx thickness compared to crystalloid solutions alone. And then, of course, there's nitric oxide. Now, not wanting to go into too much detail about this because the literature on this is vast, but we do know that albumin and hemoglobin both bind nitric oxide and actually mediate a lot of its effects around the body during health, provide a vast reservoir for its transport and storage, and of course it's the cysteine 34 residue on the albumin molecule that's actually utilized to bind with nitric oxide for transport and storage, which could be important later. But in critical illness, we know that nitric oxide homeostasis becomes disrupted with a relative excess that might cause venodilation and a drop in blood pressure. And albumin, no doubt, has the ability to scavenge nitric oxide and the reactive oxygen and nitrogen species that it is a precursor to. But when we try and upscale these findings of basic science to clinical data, it isn't quite such a straightforward story as excess nitric oxide, mop it up by albumin, and then you'll get the benefits in terms of venodilation. So the story isn't complete as yet. Perhaps lastly, in terms of the basic sciences, I want to turn focus towards albumin's vulnerability to oxidation. So reduced form of albumin, or mercaptoalbumin, or HMA in its reduced form, binds reactive nitrogen and oxygen species and becomes oxidized to non-mercaptoalbumin. And once it's done this, it's actually pretty difficult to get it reduced again. And so this will deplete your albumin's antioxidant capacity. And we know that in chronic disease, and in the outpatient clinic, for example, patients with chronic kidney disease have been found to have those with high levels of non-mercaptoalbumin, so oxidized albumin, are found to have more risk to have symptomatic cardiovascular events and a higher risk of death. And indeed, in the outpatient clinic following up patients for surgery, they found that oxidized levels of albumin in elderly women is associated with a reduced exercise tolerance when they're planning preoperative events for major surgery. So really, you've got to wonder how much oxidized and reduced albumin, the ratios, are in the bottles that we are giving to our patients, and does that carry an influence on its actual ability to enhance biological effect? So to summarize, if you're going to look at it from a pure clinical perspective, you can conclude that albumin is a safe and effective resuscitation fluid in terms of the hemodynamic endpoints that we aspire to as clinicians. Supplementation with hyperoncotic albumin might be beneficial in certain subgroups, and we await further trials to find out for sure in the coming years. But the use of both seems to be associated with a favorable fluid balance, which is something we're certainly concerned with in critical care. The biological effects that we've seen in the basic science research that you can see there, moving across, haven't really sort of been widely translated into duplicated data in humans. And you've got to wonder whether we have the right measures or the ability to measure these aspects of biological activity in our intensive care patients. And also, I think we should start thinking about the quality of the albumin that we have in our bottles and whether we should scrutinize that further. And lastly, albumin is no doubt a very expensive and precious resource. I mean, I've been involved in albumin research in the last few years that has been completely put on hold because no one is going out to donate blood during COVID-19 pandemic. And so the supply of albumin is very difficult at the moment. So you've got to wonder how relevant it may be to other countries like lower middle income countries. So where next? I think just leave you with these questions, probably more questions than answers, to be honest. But I think we do need to think about what albumin and the quality of it in the bottle and which patients am I going to actually give it to. And the only way we're going to be able to do that is to try and link up a better synergy between clinical trials and basic science, to develop some more sophisticated measures at the bedside of what's going on with crucial aspects like the glycocalyx and oxidative stress. But there's no doubt, having seen this elixir, it's been used since the 1940s and we haven't grown tired of it yet, that there's no shortage of commitment in our community to revealing the truth. Thank you very much.
Thank you. Very nice. Questions from the audience?
I may have one. Maybe I can ask a question when you go to the mic. Please. How can you measure oxidized albumin? Is it picked up by regular analyzers by a standard lab in a hospital or need special?
Yes, unfortunately, at the moment it's lab-based and it's probably liquid chromatography that you need at the bottom of it. So it's not a test at the moment we can easily bring to the bedside. The commercial manufacturers do a QC. They have the ability to do it in their labs, in their manufacturing plants, but we haven't seen it, at the bedside of patients. No.
Just to be sure, is it picked up in the total albumin level of the lab, or is it separate from the lab what we measure?
No, so your lab assay is just measuring total albumin. It's not able to discriminate between how much of it's oxidized or reduced.
Yes, I'm a bit interested in this protective effect of albumin on the glycocalyx. It's been shown in animal experiments, but it has been shown in humans, and if not, do you have any suggestion how this might be done?
Yes, it's hard because I think we see biomarkers go up, go down, associated with glycocalyx injury. We can validate that in animal studies because you can actually measure the thickness of a glycocalyx and microscopy to actually get some pictures about what it looks like in health and in disease. But whether albumin actually, its enhancement on that. I mean, you saw in the rat hypovolemic shock study that it appeared to maintain glycocalyx thickness after the hypovolemic insult. But in clinical, in humans, we just haven't been able to do that as yet, as far as I'm aware. But there is good evidence that albumin in health, for example, that it binds across the glycocalyx, not just on the surface layer, but also down on the endothelial cell layer, and probably has an influence over vascular integrity in health anyway. But yeah, the story is by far from completely understood.
So one final question. If you had all the money in the world and all the albumin needed to do it, what study would you do next? What's the study you think needs to be done next?
So the study I think that needs to be done next, it probably is, if we're going to think about critical illness and hypovolemic shock, then it is the resuscitation of shock, assisted with regular supplementation. So I'm sure Yasser can comment as well. But I think that if you're going to give albumin as a resuscitation fluid, that's great, and you'll hit your resuscitation endpoints and you'll minimize early cumulative fluid balance. But for the biological effects, you probably need some sustained exposure of albumin to the patient's vasculature and the rest of their body, and that's probably over several days and beyond. So actually the trial I would do next, which I hope to do, is resuscitation alongside supplementation with hyperoncotic solutions.
Excellent. Thank you.
Thank you.
Yeah. So our next speaker, Yasser Sakar, is going to tell us about albumin in septic patients. And he comes to us from University Hospital in Jena, Germany.
Thank you very much. So good afternoon, everybody. So I think that my task would be very easy after the two nice talks that we heard before. So I'm just going to give an overview and try to convince you about the rationale of use of albumin in patients with sepsis and septic shock, if I know how it works. So that's actually my conflict of interest. I'm the PI of a currently recruiting study on albumin administration, which is co-sponsored by Grifols, kindly supplying us with the albumin. So volume replacement therapy in the ICU is and will probably remain for the next decades as the main debate, which fluid should we use and how we use these fluids in the practice. Ideally speaking, you need some sort of a solution that remains intravascularly to expand the circulation and to have the maximum volume expansion effects. So colloids are theoretically the best solutions to give, I mean theoretically. But the safety of colloids have been questioned over the last years. As you know, all the currently available synthetic colloids are having a lot of side effects that may actually hinder the use of these substances in everyday practice. So albumin is a natural product, so we have it, and in our body normally has a specific function. And I think it's not surprising that our liver spends like 70% of its energy expenditure in producing albumin. So it should be, theoretically speaking, a good thing if you need to, pay a lot of energy to produce it in your body, and especially in critically ill patients where hypoalbuminemia is a great concern due to several reasons. But here we have to try to differentiate between two indications of the use of human albumin, using it as a volume expansion therapy, as the first speaker have nicely shown about albumin and albumin solutions, or using it as a drug of specific properties like the ones that I'm going to discuss later and that have been shown also by the previous lecture about the antioxidant effects. I don't know, I'm not going to go into details of all these experimental facts, let's say. So albumin is good, as shown in the first lecture. It maintains the colloid oncotic pressure and effectively expands the intravascular volume. It improves the microcirculatory flow and renal blood flow and so on. And it may also, according to some animal experiments, some experimental models, inhibit the sepsis-induced cardiomyopathy, and it has, of course, the antioxidant effects and the immune modulatory effects, and it may also increase diuretic effects using it simultaneously with furosemide. The most important thing about albumin is that it being a natural product, that is actually the safest colloid that we know. And all the other synthetic colloids, as I said in the beginning, are associated with a lot of side effects which may be deleterious in patients with sepsis. As you can see here, the antioxidant effect of human albumin, which is related to the amount of albumin that we have, human serum albumin that we have in our blood. But again, not all the albumin that we have in our blood is actually viable albumin, as shown in the previous lecture about the oxidized and non-oxidized albumin, which means that if you have a total albumin more than 30 grams per deciliter, that doesn't mean that all your albumin functions appropriately and all your albumin can exert these beneficial effects in terms of immunomodulation. In this nice experiment of sepsis and acute lung injury, you can see here a very nice sections of the lung of these experimental models, which are resuscitated with Binger's lactate, a lot of inflammatory cells in the alveoli. But if you do the same experiment and resuscitate the animals using 5% human albumin, you have a little bit of less inflammatory reaction and less inflammatory cells. But if you use the human albumin of 25% concentration, you have much less inflammatory effect and inflammatory cells, which means that even within the albumin solutions, you have more albumin solutions that may exert more antioxidant and immune modulatory effect and maybe having other properties rather than the volume expansion effect that you may expect from these solutions. And indeed, a lot of human studies have looked at that, supplementing critically ill patients and patients with sepsis with human albumin, such as this study from the Brussels group with Marc-Jacques Dubois and Jean-Louis Vincent. As you can see here in these two groups of patients who were resuscitated either with human albumin, with human albumin and using other solutions, that patients who were resuscitated with human albumin have actually more favorable pattern of organ function all over the ICU stay. So albumin may be beneficial in these patients indeed. And by the end, when you think about human albumin, it's actually a natural product, but we give it as a drug. It's produced outside the body, so it may also have some sort of side effects that may explain that the beneficial effects would not be seen in every critically ill patient, especially in patients with sepsis. We have also a list of possible bad sides of albumin being a product, a blood product. It may be subjected to infections, for example, cardiac decompensation. If you use it the wrong way, you give a very large amount of human albumin in patients with cardiac decompensation. So antiplatelet effects, extravascular retention, as discussed during the first lecture. It may exudate in patients with sepsis due to capillary leakage. And then by the end, if you don't drain this albumin through the lymph, so it would be having exactly the other thing that you don't want to have, which is edema, draining fluids, in the interstitium, and which is not drained by the lymphatic system, may also impair myocardial contractility in some experiments, immunosuppressive effects, and so on, which have been shown in some of the experiments, which is not really related to the albumin by itself, but how the albumin is prepared by some companies. Most of the recent albumin preparations would not have this sort of side effects. And by the end, of course, the cost of human albumin. So you can buy the same amount of albumin, you can buy actually 30 times of crystalloids using the same money. So, and also, the subsequent studies on human administration, which is always mixed the two effects, the volume expanding effect with the albumin being a drug effect, and looked at the outcome in critically ill patients. It was a big problem in the interpretation of the results of these studies. And if you are gray-haired in this room, you will, of course, remember this meta-analysis, which at the time had a very large impact on our practice in the ICU around 20 years ago, showing that albumin may be very bad, may be killing patients in the ICU because it may impair their potential to live more. Of course, this meta-analysis have included a lot of studies that were performed in very small subgroups of critically ill patients, and it did not include a lot of studies that showed that albumin had a favorable effect in critically ill patients. So doing another meta-analysis and another meta-analysis, including more studies, have shown that it may be associated with a better outcome, actually. So there was some sort of discrepancy when you put the studies together. Actually, you don't have to be surprised about that, because all these studies are different contexts in the ICU, how you give the albumin and to which patients are you giving the albumin and which way you give the albumin, which quantity and with which protocol and so on, which is actually the main determinant of the success of fluid resuscitation. So whatever the fluid that you are using in your ICU, even it's the best one and it's going to exert all the possible anti-inflammatory effects, if you give a large amount of it in a patient with a cardiac decompensation, for example, so the patient will die from cardiac dysfunction, not from the albumin that you have given. So that may be an explanation why some of the studies have shown deleterious effects. Of course, we have the SAFE study, which have shown us that albumin, even used the way they gave it in the SAFE study, which was actually a way that if the patient needed fluid, he receives albumin, 4%. So it's a more, let's say, liberal way of giving albumin. We would not do that in our everyday practice in every patient admitted to our hospital. It's very costly, and it's actually more or less, if you think about it, clinically speaking, it's some sort of let's say, nonsense, I would say, because I would not give a post-operative stable patient 5%, 4% albumin just because I think that he needs some sort of daily replacement therapy of fluids, So again, this study, despite of the fact that it has given albumin very liberally to the patients assigned to the albumin group, have shown that albumin was safe even even if you give a large amount of it to patients who needs fluids. And again, as being alluded to in the previous talk, the subgroup of patients with sepsis in the SAFE study have shown a potential to get better if they receive albumin. And this was confirmed also in the multivariable analysis if you adjust for possible confounders that you have in your patients. So albumin may indeed be useful in patients with sepsis. Not because it's a volume replacement therapy alone. It may be also beneficial to give, or be good to give albumin because it is a drug that may exert anti-inflammatory and immune modulatory effects. And that have been shown also nicely in this meta-analysis. And that may have been the reason that the Albus study have been conducted in Italy. And again, the Albus study is not the SAFE study, again, because the SAFE study was actually a volume replacement therapy study, but the Albus study was a drug therapy. So albumin was given here as a drug, not as a volume replacement therapy. So patients who had severe sepsis received 20% human albumin to maintain the serum level above 30 grams per deciliter. And this was done over 28 days in the ICU. The study didn't show a global benefit from albumin administration, but the subgroup of patients who had septic shock in the Albus study have shown a benefit, a signal towards benefit. So patients who received albumin and had septic shock tend to do better than patients who did not receive human albumin. And again, it's not a volume replacement therapy study. It was albumin as a drug therapy. And interestingly, the effect of albumin was actually better shown in patients who started to receive albumin after 6 hours from the onset of septic shock, which means that giving it early in the course of the disease may not be actually the thing that made the difference in the study. So if you start it late, it would be also okay, because maybe in the other group, like what we do in our everyday practice, you usually start with large amounts of fluids to resuscitate the patients. So in the beginning, the difference is made by the volume expanding effect, but the later effect shown in the albumin group is due to the antioxidant immunomodulatory effects of albumin. And that was the reason that several studies are on the way recruiting, including our ARES study. It's a German study recruiting patients according to the Albus protocol. So we are recruiting patients to receive whether human albumin 20% versus patients who receive resuscitation using crystalloids or other volume replacement therapies. We have recruited so far about 330 patients, but we still need to recruit about 1,200 or 1,300. So I hope that the study will end within the next few years. Let's hope that. There is also the Albus 2 study. I didn't have a slide to show, but it's running in Italy with the same pace. They also included like 350 patients so far. It has a little bit different protocol of inclusion, but it's more or less the same concept, giving albumin as a drug therapy, not as a volume replacement therapy. So let me conclude. I think that we would agree that human albumin is safe for the use as a volume replacement therapy in critically ill patients that have been also nicely shown in the previous two talks. The indication for colloid administration, in my personal opinion, is actually the main concern rather than the type of colloids. So I would say so far, according to the current evidence, it's how you give the fluids that matters, not which type of fluid so far. The current evidence does not justify the routine use of human albumin in the everyday practice. However, the therapeutic use of human albumin in patients with septic shock may be beneficial, so you should consider it if you have it in your institution and you don't have problems with your administration, because usually, albumin is usually ranking the first or the second drug in the expenses of your ICU. So if you have a very strict administration, it would actually argue against the use of albumin. But we can do nothing against that. Thank you very much.
Thank you very much, Dr. Sacker. Any questions from the audience? I have another question. Sometimes, because there's some evidence showing that maybe a later phase dry approach to critical illness is maybe better for the final outcome. Is there a place to give albumin in combination with diuretics, maybe in a later phase of critical illness? What is your opinion about that?
Well, yeah, of course. It's actually there is a rationale behind doing that, but I'm not aware of any studies running in this respect. But we usually do it in our everyday practice. I myself, I do it liberally in my ICU. When you see the patient have a lot of edema and you need to do some negative balance and so on, a very good approach is to give albumin and diuretics at the same time to increase the urinary output and put him onto the negative side. Of course, it can be, and maybe also one of the mechanisms why human albumin would work in patients with septic shock too, because we are not giving a lot of albumin in the ICU using the 20% in the protocol that we use for the ARIS and the Albus 2 study. So it's only if the serum albumin is below 30 grams per deciliter, and with very small amounts, indeed.
No other questions here? No? Then I would like to thank you for your presentation.
Thank you very much.
We just continue, I think. Yeah. So the next speaker will be Paolo Angeli from the Unit of Internal Medicine and Hepatology from the University of Padova in Italy, and will address the role of albumin administration in cirrhotic patients.
Mr. Chairman, dear colleagues, first of all, I want to thank Jean-Louis for this kind invitation. It is always a great pleasure for me to be here. This is the complex of my disclosure, but after that, I will present briefly my agenda that is very simple. First, I will discuss about new developments on the pathophysiology of decompensation in patients with cirrhosis, and then I will speak about new developments on the use of albumin in this patient, particularly referring to responsive ascites and refractory ascites. Let me move from the beginning. Because, you know, we went on more than 30 years thinking that the only driver of decompensation was a progressive increase in portal pressure, a related progressive derangement in cardiovascular function, a progressive related increase in the degree of activation of vasoactive and sodium-retaining factors. For sure, this is true, but this is only part of the truth. Why? First, because if you look to this slide, you can realize that there is no progressive increase in the degree of activation of vasoactive factors, at least in the most advanced phases of the liver disease. Second, we are able to modulate these factors. We are able to reduce the activity, for example, of plasma renin, without obtaining for this any significant impact on clinical outcomes. No reduction of the rate of complication, no improvement on survival. Third, more important, because during the last 10 years, we learned that at any stage of the liver disease, but particularly in decompensated cirrhosis, a new syndrome may develop, that is acute on chronic liver failure, which is characterized by an abrupt onset, organ failure, and tremendous negative impact on 28-day survival. Now a patient may develop organ failure and may develop ACLF, even in presence of normal value of vasoactive, but never in absence of systemic inflammation. So systemic inflammation may be a second powerful driver of decompensation. Systemic inflammation is not only present in patients with cirrhosis who develop organ failure. Systemic inflammation is still present in patients with cirrhosis who develop acute decompensation. What is acute decompensation? Is that the sudden onset of one or more than one major complication of the liver disease, ascitic, hepatic encephalopathy, bleeding, and bacterial infection. But the onset of systemic inflammation is more an early event in the course of the liver disease. Systemic inflammation is still present in patients who have grade 1 ascites. I want to remind you, grade 1 ascites is ascites that can be detected only by abdominal ultrasonography. And you know, systemic inflammation will worsen thereafter in patients with grade 2, grade 3 ascites, and overall in patients with difficult to treat ascites, such as patients with responsive ascites and patients with refractory ascites. So systemic inflammation is a powerful driver of decompensation. A third potential driver of decompensation is oxidative stress. This is the molecule of albumin, and you all know that in position 34, there is a residue of cysteine that is capable to bind ROS. In doing so, albumin is oxidized either in a reversible form, non-mercaptoalbumin 1, or in an irreversible form, non-mercaptoalbumin 2. And you can see that the sum of oxidized albumin is progressively increasing along the course of the liver disease. So a third potential driver is oxidative stress. And so the problem is how we can put all together: progressive increase in portal hypertension, oxidative stress, and systemic inflammation in a new theory, of course. And nowadays, we think that the main consequence of portal hypertension and liver failure is bacteria translocation, which is responsible for systemic inflammation and oxidative stress, which are the only cause of the cardiovascular dysfunction and of the reduction of the effective circulating volume. There are no other mechanisms by which portal hypertension and liver failure can induce this cardiovascular dysfunction. And then the effective hypovolemia, together with oxidative stress and the systemic inflammation, can cause the onset of ascites. But let me say that systemic inflammation and oxidative stress generate a vicious cycle. So there is a further increase in portal hypertension, liver failure, a further increase in the degree of bacteria translocation, and at the end of the day, a final increase in the degree of systemic inflammation and oxidative stress. So at any time along the course of the liver disease, organ failure may develop spontaneously or with the intervention of a precipitating factor at the hepatic level or at the extrahepatic level. But let me move now on the clinical ground, and I will start from responsive ascites, which is the standard medical treatment of responsive ascites. I will not speak about the short-term use of albumin, because the short-term use of albumin has very clear and well-proved indications that are the following: the prevention of post-paracentesis circulatory dysfunction, the prevention of AKI in patients who develop spontaneous bacterial peritonitis, and together with terlipressin, the treatment of hepatorenal syndrome. In all these indications, it is well proven that albumin improves survival in this patient. But I will go back to responsive ascites. I will not speak about the short-term use of albumin. I will speak about the long-term use of albumin. So the standard of care for responsive ascites is moderate sodium restriction and diuretics. The question is, can we do something better? Yes, we can do. We can give albumin. This is a result of the ANSA study we performed some years ago in Italy. It is a multi-center controlled clinical study comparing, the standard medical treatment versus the standard medical treatment plus the long-term use of albumin, 40 grams of albumin per week for 18 months. And you can see that the long-term use of albumin was capable to prevent the development of refractory ascites, was capable to prevent spontaneous bacterial peritonitis, other infection, was capable to prevent hepatic encephalopathy and hyponatremia. But overall, the long-term use of albumin was capable to improve survival. The secret is to give enough albumin for a long period of time. What makes the difference between patients in whom the long-term use of albumin is beneficial on survival is to get as soon as possible a normal serum albumin concentration. And let me say that it makes no sense to use albumin for 1 week, 2 weeks, 3 weeks, because this will not have any effect on the clinical outcome. Let me move now to refractory ascites, which is the first option for refractory ascites, of course, therapeutic paracentesis. And we suggest to use albumin as plasma expander independently of the volume of ascitic fluid removed, because we have no alternative in this setting. But when therapeutic paracentesis become too frequent, more than 3 in a month, what we can propose to our patient? We can propose tips. But if you consider the contraindication to tips, there are several, you can realize that you cannot propose TIP in more than 50% of your patients with refractory ascites. So the question is, what we can propose else? You know, the alpha pump and the chronic use of vasoconstrictor need to be further proved by controlled clinical trial before to be suggested for the use in clinical practice. So what we propose in our unit in patients with refractory ascites is the long-term use of albumin, 40 grams per week. We performed this real-world trial, it's not a controlled clinical trial, in 70 patients with true refractory ascites, comparing the standard of care versus the standard of care plus long-term use of albumin. And albumin was capable to reduce the mortality rate, to reduce the rate of emergent readmission to the hospital for all the complications of the liver disease, with only one exception, variceal bleeding. We think that in the long term, albumin is exerting not only through the oncotic properties of the molecule, but through the non-oncotic properties of the molecule that are several. But I want to focus on one of them, the anti-inflammatory action. Albumin is capable to go into the immunocell, the green point you can see in these slides, particularly when there is a pro-inflammatory state. I'm referring to leukocyte, but also to mononuclear cell. And within this cell, albumin is capable to reduce the production and the release of the pro-inflammatory cytokine. Not only this, albumin is also capable to protect the cell from the action of the pro-inflammatory cytokine. These are hepatocytes from mice, and you can see the effect of albumin on the prevention of the effect on the hepatocyte of LPS and hepatic toxin, the D-galactosamine. Why? Because albumin is capable to prevent the effect of TNF-alpha on lysosome, so the release of cathepsin B. And so albumin is capable to prevent the release from the mitochondria of cytochrome C, and so to prevent the activation of the caspase cascade. You can say, oh, this guy is here speaking about cell. So let me move to an experimental model of decompensation, rat with ascites. And you can see that in the cardiac tissue of this experimental model, albumin is capable to normalize the expression of the TNF-alpha protein. Doing so, albumin is capable to normalize the expression of the iNOS protein. So it is capable to reduce the production of nitric oxide within the cardiac tissue. And by this, albumin is capable to recover the cardiac contractility in this experimental model. This is not true for any other plasma expander. You can say, wow, this is an experimental model, but we have proved recently this aspect also in patients with cirrhosis and acute decompensation. Albumin is capable to recover the cardiac function also in these patients. So let me summarize what I said. Decompensation of cirrhosis is not only related to a progressive increase in portal hypertension, but also to systemic inflammation and oxidative stress. Short-term use of albumin is a well-recognized therapeutical option in the prevention of post-paracentesis circulatory dysfunction, in the prevention of AKI, and in the treatment of HRS-AKI. In all these conditions, albumin improves survival. In patients with responsive ascites and refractory ascites, the long-term use of albumin is capable to reduce mortality and to improve the quality of life. And finally, in all these conditions, albumin is exerting not only through its oncotic properties, but overall through its non-oncotic properties, and particularly its anti-inflammatory action. Thank you very much for your attention.
Thank you very much. Any questions from the audience? I wondered, with respect to this prolonged administration in the cirrhotic patients, do you target a specific albumin level, or do you give just a fixed dose every time you take the patients in?
We started the trial with a fixed dose, but I think that waiting for a lab method to detect non-oxidized albumin, the target should be to normalize the serum albumin concentration. Okay. So in between 3.5 and 4
and maybe
gram DL.
From a financial perspective, because it seems a rather costly therapy for prolonged use in these patients, but probably the benefits of progression of the disease outweighs the cost of the treatment. Is that right?
Of course, there are several other modifying disease agent that is under investigation. The use of albumin in long term is cost effective. Okay. The problem is not the cost, the problem is the availability.
Okay. Great. No more questions? Thank you very much.
Thank you very much.
Excellent presentation. Thank you.
So our final speaker, Dr. Hernando Gomez from the University of Pittsburgh, will answer the question, or ask the question, that albumin can improve survival. Thank you.
Thank you, Mr. Chairman. Is there a pointer?
Yeah, on the...
this one?
Usually,
oh,
yeah,
okay.
Yeah.
Thank you.
There you go.
Well, thank you, Mr. Chairman. Very happy to be here with you today. And well, I have very little to say after these excellent talks that we've heard during the day. I'm going to try to put together a little bit of an idea of what albumin can do for improving survival in patients with critical illness. Let me see if I can make this work. So these are my disclosures. So in putting this talk together, I could not help the feeling of deja vu. When I was a fellow in critical care medicine back in 2009, this paper came out, and I chose it to present my journal club because I spent some time with Professor Mancebo in wonderful Barcelona, in the Hospital San Pau there. And he was actually doing this flip-flopping of patients prone, teaching me how things were done. And actually, I probably helped some of the patients that appeared in the trial afterwards. But in any case, the previous trial to that trial was negative. That trial was negative itself. Then a meta-analysis came out saying that perhaps a subgroup of patients would be responsive to proning. And then, of course, the famous PROSIVA trial came back, showing that there was a benefit for survival in the specific group of patients that were extremely sick, and the rest is history. We use it for our patients today. Well, the pendulum of evidence, as you've heard throughout the afternoon, in albumin has been similar. It started with a lot of enthusiasm when it became available in the 40s. Then it fell in disgrace with a famous meta-analysis in the British Medical Journal suggesting that there was harm. And then after the SAFE trial, we have sort of settled into this midpoint where we're trying to find out which is the right population to give it to, as you've heard throughout the afternoon. And we've heard that the best evidence we have is probably in the liver patients, as you very well heard right now. There's some hope in septic shock patients. And I want to try to convince you to consider this other group of patients, the patients that are exposed to large volume resuscitation. And we'll discuss why. So I'll say a couple of things about septic shock, but then delve into the large volume resuscitation. So you've seen this data already. These are subgroup analysis essentially from the big trials that have shown that specific subgroups might actually hold a clue to whether or not albumin is protective and increases survival. This is the subgroup analysis of the SAFE trial, and this is a post-hoc analysis that demonstrated that there was a potential survival effect. The EARS trial, that to my knowledge was only published as an abstract so far, but essentially did not show any differences, maybe a trend towards improved mortality with albumin, but again, this was non-significant. And of course, finally, the Albus trial that came out showing again in the subgroup analysis that perhaps patients in septic shock would be the population. Then many meta-analyses came back showing differential effects, as you've seen. This is Delaney's. This is one from Patel that demonstrated that there was no effect. But when you take out the small trials, and this very interesting letter that Wiedemann and Ioannidis sent to the New England Journal of Medicine suggested that perhaps in these big trials we could see an effect. And there was another interesting network meta-analysis performed by Bansol that demonstrated using a different methodology that perhaps albumin had a protective effect on survival. And furthermore, they suggested in a different paper that it could potentially be cost-effective in this realm if you include all of the other bad things that could happen by giving only very large amounts of crystalloids. Of course, there's controversy about this, and administrators in hospitals, are always a problem, I guess. But in any case, I think in the words of Professor Deborah Cook, which are absolutely relevant today as they were when she wrote the editorial for the SAFE trial, from the perspective of research, the affair with albumin in intensive care unit is probably not over. And we're very excited to see what the results of the newer trials will bring. So that's all I'm going to say about sepsis. But why consider large volume resuscitation in the critically ill? And basically because these patients are exposed to more of the adverse effects that you would see when you give crystalloids, in the form of exacerbation of hypoalbuminemia that has been over and over and over again demonstrated to be bad for patients. denudation of the glycocalyx, and of course exposure to increased risk of volume overload with the consequences of increasing venous pressure and causing organ dysfunction secondary to congestion. The other thing is that there's a lot of paucity data in this specific population that receive massive amounts of volume. And of course, there's also this, which is the recommendation by the Survive Sepsis campaign, the last iteration, that suggests that in patients, when you're giving too much fluid, you should potentially consider albumin. However, as they will describe, the recommendation is weak, and perhaps we should look at that more closely. So let's look at the evidence that this perhaps is real in terms of biological plausibility. So this is a subgroup sub-study analysis of the PROCESS trial. The PROCESS trial was a trial that was looking into the effectiveness of protocolized care for the resuscitation of sepsis patients. And what they showed in this study in particular was that cumulative intravenous fluids was an independent predictor of shedding of the glycocalyx, at least as measured by heparan sulfate, which is one of the components. In this cell culture study, you see a lot of green there. That means that there's a lot of heparan sulfate and chondroitin sulfate, which are components of the glycocalyx. And that happens when you have high albumin environment. But look at what happens when you start devoiding those cells off of albumin. And you see how the glycocalyx is essentially completely devastated. And this is only a cell culture. This is no inflammation. There's nothing else other than albumin here. So hypoalbuminemia is a real problem. Now, you've heard that, denudating the glycocalyx is an important thing because it causes dire consequences, like, for example, increasing inflammation, increasing endothelial activation, microthrombosis, rarefaction of the microvascular flow, and of course all the consequences that we know from that. But there's also the risk of patients that receive too much volume, perhaps increasing filling pressures, that you will start to have problems at the venous end of the organs, that they're well perfused from the arterial side, but they cannot get rid of the volume on the other side, and they start developing edema and dysfunction because of that mechanism. So I hope I convinced you that there's biological rationale for this. And so we conducted a retrospective study to look at this. Our hypothesis was that exposure to 5% albumin would be associated with a lower in-hospital mortality in patients with large volume resuscitation, defined as patients that were given 60 mLs per kilo or more within a 24-hour window. It was a retrospective study that used this data set, which is the high-density intensive care data set, which is composed of ICU patients that came to any of the 13 academic hospitals in our institution, and that's the exposure that we talked about. We compared 5% albumin against saline, and the primary outcome was hospital mortality truncated at 30 days. And the secondary outcomes was the usual suspects, right? 90-day and 1-year mortality, moderate to severe AKI, AKI recovery, and MAKE, which is major adverse kidney events, which is a composite of death, RRT need, or progression of AKI. So primary analysis was done using multivariate logistic regression, using these variables that you see in the directed acyclic graph, which are confounders that could potentially alter the outcome and the exposure. And we confirmed using propensity score matching as an alternative technique. This is our consort diagram. We, from 164,000 patients, we decreased it to about a final cohort of 16,000 patients, of which about a little bit more than 14,000 got saline, and 5%, 1,800 received albumin. This cohort, by the way, is about 9.8%, so potentially your patients too, but it's at least it's real in our institution. So it's a sizable quantity of patients. And these are our results. We found that there was a significant protection in mortality in patients that were treated with 5% albumin as compared to saline. And that, of course, extended to 90 days and 365 days. And furthermore, we confirmed that in our propensity score matched cohort. this was also associated with a couple of things. One, it was associated with an increase in the total output of patients, but also a decrease in the total intake of fluid and fluid balance, suggesting perhaps that the use of albumin in the long run ended up decreasing the amount of volume that these patients ultimately got. And maybe that was one of the mechanisms, but of course that's just hypothesis generating. Here's the thing, this we did not expect. So we found that actually exposure to albumin was associated with an increase, not a decrease, an increase in the development of acute kidney injury. And this was any AKI or severe AKI. So how do we reconciliate a decrease in mortality with an increase in AKI? And well, when in Brussels, let me try to address that elephant in the room. We know that persistent AKI and not transient AKI is what drives your mortality. Persistent AKI, actually transient AKI is the AKI that occurs within the 2 and 7 day window. And if you reverse your KDIGO criteria to 0, then you are said to be recovered. If, on the other hand, you continue to have at least a KDIGO criteria of more than 1 beyond the 7 day window, you are said to be in persistent AKI, and that is what changes mortality. As you can see in this study, if you have persistent AKI, transient AKI, you have essentially the same mortality of a patient that never developed AKI in the first place when you're septic. However, if you get any other flavor of persistent AKI, you get a decrease in survival. In our cohort, we found that albumin was actually associated with a decrease in MAKE, major adverse kidney events, and actually none of the patients that were exposed to albumin required renal replacement therapy, suggesting that these patients were not developing persistent AKI, but rather just transient AKI. And then we can reconciliate the fact that we had a signal for AKI that was acute, and I cannot explain in reality why these patients look like that, of course, under the caveats of this being a retrospective analysis. But at least we can say that if it was transient AKI indeed, then there was no effect on mortality, and our results are congruent with what we would expect. So in conclusion, there is a strong physiologic and pathophysiologic foundation for the use of albumin in critical illness. I think that's important to recognize, and I think that's why the field and everybody tries to push for this, to try to find the right patients to give it to. The protective mechanisms are still unclear, but may include many, many things, as you've heard so far. I just cited a couple of things here. It is highly unlikely that albumin causes harm. I mean, we have very good data suggesting that it's safe in these patients. Of course, with the caveats of other adverse effects, but again, we have very good RCT data that shows that this is safe. And the clinical evidence is accumulating just as it accumulated with proning. Again, just going back to that, it accumulated and accumulated and accumulated until it just went through. And it seems like the potential subgroups that we should be looking at is clearly the spontaneous bacterial peritonitis, potentially septic shock, and then patients potentially with subjected to large volume resuscitation. So with that, I thank you for your attention. I want to acknowledge Priyanka, who was our statistician to do this massive analysis, and of course, John Kellum, who's been my mentor. Thank you.
Excellent presentation. Questions from the audience, please.
Maybe a question. Did you see like a dose-response relation between the administration of the albumin and the outcomes?
Yeah, thanks for that question. That's we flirted with the idea of putting that figure in the paper, but we thought that we were going to go and get into reviewer hell just because it was retrospective. We did have a signal for dose response, but again, we didn't want to just say so, because again, there's just too many caveats to a retrospective analysis. But yeah, we saw it.
Okay. Yes, please.
I wonder if you are aware of any selection bias between the patients that received albumin and those that received saline.
Yes, I mean, that's the million-dollar question with this type of studies. You hit it on the head, and that's the selection bias that we fight against. The way we try to, deal with that during this study was, again, doing the multivariate logistic regression, trying to address these potential confounders. And that's the other reason why we use propensity score matching, because the propensity score matching that we used was using variables that were associated with the probability of you getting albumin versus saline, right? So that's what we try to do. But again, being retrospective is difficult to eliminate entirely that bias. This will definitely need prospective trials to.
But what are the thoughts in the US about the indication for albumin versus saline in the setting? It might be different than
In the critically ill patients?
Yeah, maybe if you feel that the patient is more hypovolemic, maybe you would want to give albumin or that kind of.
Absolutely, and that was a great idea. I should have put that in my disclosures too, because I do give albumin to critically ill patients. I think we all do, every now and then, but my administrators are pretty tight on it, so I have to fly under the radar. Usually patients that are requiring a lot of fluid, I try to mix with albumin just to try to decrease the amount of volume that we're giving. I've used it also not with, of course with diuretics when we're trying to de-escalate therapy, but also when patients are on CRRT and we're trying to remove fluid and we cannot remove fluid fast enough. Giving albumin sometimes helps maintain a little bit of the intravascular volume and allow for more volume removal that makes the patient, kind of progress a little bit better. In cardiac surgery, we're really not using it. We used to use it a lot. But it's definitely something that is cultural in the hospital. It was completely eliminated from the possibility of actually giving it. So we're tethered. We cannot use it. Would I give it? Yeah, for sure I would give it. Because I do believe that it has many things that are good. And just like that study, the cost effectiveness study that I showed you, maybe including all of the things that albumin can do well and avoid from the bad things that crystalloids can do, will demonstrate in the long run a cost effectiveness.
Thank you.
That answers.
Maybe a last short question.
Just very short. Do you have any data considering hyperoncotic albumin, or is just culture bisbutyrate 4% albumin?
Yeah, in my hospital, you mean? Yeah. So the study was with 5% albumin, which is what we have there. I fly under the radar with 20% albumin because that's not screened that much in my hospital. Please don't tell anybody in Pittsburgh. But the 5% albumin is a little bit less available now because of that policy. Yeah.
Okay, thank you very much for this excellent presentation. This session has come to an end. It was an excellent session about albumin. We learned a lot, and have a good time here at the Congress. Goodbye.
Thank you.